All of you. Thank you for joining us for today's international webinar on cognition and communication difficulties in dementia in the eve of World Alzheimer's Month, organized by Alzheimer's and Related Disorders Society of India in Mysuru chapter in association with Chadavilas College of Pharmacy, Mysuru. I am Dr. Rosi Raju, Coordinator and Assistant Professor to Department of Pharmacy Practice, Chadavilas College of Pharmacy, Mysuru. Today I would like to a few points about the Alzheimer's disease. And Alzheimer's disease is a neurologic disease that affects the brain. If Alzheimer's is the common cause of dementia among older adults, so Alzheimer's disease is the fourth leading cause of death for adults. And early onset Alzheimer's occurs between a person's 30s and mid-60s and is very rare. 5 out of 100 elderly in India have dementia, and many more are at high risk of developing this condition. A gradual loss of memory is one of the main symptoms that a person experiences with Alzheimer's. They also have problems with language and changes in behaviors, mood, or personality. Now, I request Dr. Hanumanthachar Joshi, Convener and Principal, Chadavilas College of Pharmacy, Mysuru, President, RC Mysuru Chapter, to deliver the welcome address.
Very good morning, everyone. And first of all, wish you all a very World Pharmacist Day. Yesterday we had it. First of all, we are very happy that Yves is joining, Dr. Yves Joanette, who is a very acclaimed researcher in dementia in the world. We can say he's an authority who can speak very authoritatively on aspects of dementia. He was the chairman of World Dementia Council. And our association with Dr. Joanette is not new. First time I had met him in a AIC conference, that is Alzheimer's Association International Conference, which was held in Canada. During a meeting of the Medical Scientific Advisory Panel, I was asked by Dr. Jacob to join, and we had planned an international conference at Mysore at that time in 2016. And second time we met in another conference of AIC, a very wonderful person. And we were very fortunate to have him in Mysore in 2016 as the eminent guest as a speaker. He himself, along with his wife, had attended that. And a hearty welcome to Dr. Yves for joining us. And he will be speaking on the communication and as well as cognition difficulties in dementia. Because in this World Alzheimer's Month, we have been approaching and we have been emphasizing on various issues of dementia. But whereas the communication and cognition are very two important factors which are normally affecting the dementia patients, which are not normally addressed. Because many times we feel because the people are already aged, they will not be able to communicate properly with the patient caregivers. That's the very idea that Dr. Yves Joanette has taken a wonderful topic, and he will be definitely deliberating on that in this international webinar. And once again I welcome Dr. Yves Joanette, who will be joining us directly from Canada, Quebec. At the same time, we have one more very international and, as you know, the very eminent personality of the pharmacology profession in the country, Dr. Milind Parle, sir. Sir, a very hearty welcome to you, sir. Sir, welcome to you. And he doesn't need much introduction because you would have seen him in many platforms. Dr. Milind Parle is the honorary president of Association of Pharmaceutical Scientists and Educators, and he was the former dean of Department of Pharmaceutical Sciences, Guru Jambesh University of Science and Technology, Haryana, Hisar. So a hearty welcome to you, sir, once again. And without spending much time on this, I welcome all the delegates who have joined here. I can see very eminent people who have joined in the delegate. There are so many people from across the country and across the world also have joined. And all people are very eager to listen to Dr. Parle and as well as Dr. Yves. So once again, welcome to you all, and thank you so much.
Thank you, sir. And we also welcome you for the international webinar. Now I request Chief Guest Dr. Milind Parle, President, Association of Pharmaceutical Scientists and Educators, today's Asia Pacific, former Dean, Faculty of Pharmaceutical Sciences, Guru Jambeshwar University of Science and Technology, Hisar, to deliver his inaugural address. Over to you, sir.
Okay. Good morning, everybody. Can you hear me?
Yes, sir.
Right. See, the topic today is very interesting. the difficulties we face with patients suffering from dementia. It's a typical problem. You know, whatever we are because of our memory. I'll tell you a small instance. Take one of us, say Mr. Garvit wants to have a trekking near Ladakh, and he visits beyond Kashmir in the cold season where there is a ice lake, and Garvit enjoys skiing on ice, you know. So it's very cold there, and while skiing, suddenly he notices that he has lost the way. His legs have become cold, his hands have become cold. Suddenly entire body is cold and he is wandering. He doesn't know where to come and how to return back. And suddenly he is lost. Now put yourself in his shoes. You have a frozen body and you are lost. You don't know how many days, how many weeks, how many months your body is frozen. You're on ice floor. And one day, when you wake up, you look at your dress, you're wearing an altogether different dress. And the field is new. You are unable to identify anybody. You have forgotten your own name. You do not know what you are. Yes, you can speak English, you can speak Hindi, but you see Chinese people around. Are you in China? Are you in a new field? And the person who comes to you bringing cup of coffee is Chinese, altogether a new face. Mr. Garvit has lost his memory. He has forgotten. He has forgotten that he had gone for trekking on the ice skiing, and totally he doesn't remember anything of his native place, of his qualification, of his parents. Imagine this situation. And a similar situation, this is dementia. This is a typical retrograde dementia in which you have forgotten everything. Now imagine such a situation occurs in elderly individuals who are suffering from memory loss. Now how to take care of such persons? So that is what, it's not difficult. Can I have the next slide, please? See, we are all not born as good caregivers. We do not know how to take care of persons who are suffering from dementia. But yes, this is the skill which can be acquired. So, what one can do is, you have to first, when you are with a patient suffering from dementia, you have to strive to get his attention. If you are able to get his attention, then you have done a big job.
No, I think he has some internet issues. He'll be joining soon.
സാറിനെ വിളിച്ചു നോക്കി അങ്ങേര് വരുന്നത്
It seems there are some internet issues with him.
Yes, sir. Yes, sir.
Now, meanwhile, before he joins, let me tell you some of the salient points. How the RC is involved in the various aspects of dementia here. See, the RC was established, especially the Mysore chapter, was established in 2012, and it is involved in the various the advocacies. It is not only okay. It is not only involved in conducting webinars or something. We keep on doing various programs throughout the year, like the conducting the memory works for the awareness of Alzheimer, and we also conduct some trekking, and mainly to help the people with dementia and especially dementia caregivers. People with dementia, they will be in their own world because they will already suffer from the various issues of memory dysfunction. But the major challenge is with the patient caregivers, because they have to understand the disease, they have to take care of the dementia patients. So this is really a cause of real concern. So the RC is involved in that. Not only that, it also helps in dementia care centers. We have the facility here in association with River Hospital. It has got both the daycare center and as well as the residential care center, where the dementia patients are treated. They have been taken care. But as you know very well, dementia doesn't have any kind of the complete remedy. It has got some drugs in the market like donepezil, rivastigmine, galantamine, but they have got some serious toxic effects, especially the passing of the urine and stools in the bed itself, which is a cause of concern for the patient caregivers. So our idea is to make an awareness among the entire the country, especially in Mysore district. So we also give them the tips, especially to the patient caregivers, like how to take care of the patient and what are the normal symptoms of dementia, and we also help them giving the legal advices and all. So this is the activity of RC, and RC is a part of Alzheimer Disease International, which is based in UK. Around 80 countries are the part of it, and India RC is the organization which takes care of all this. There are around 24 chapters across the country. And in Karnataka, there are 2 chapters. One is in Bangalore, other one is in Mysore. So we are conducting all these programs throughout the year, but especially in the month of September, because it is regarded as the World Alzheimer Month. This is what I wanted to inform, and I am sure very soon Dr. Parle will join. Hello. Now may I request before I think Dr. Parle is facing some difficulty. May I request Dr. Yves to kindly start his talk. Dr. Yves, I request you to kindly start your talk.
Hello, everyone. I regret I'm not able to be physically with you in Mysuru, but it is a pleasure to be there virtually. At least this is the way it can
Dr.
be
Rosie,
done this year.
can you introduce the speaker?
We are very,
Yes, sir.
we are very
before he starts talking.
We think about.
It's
No. Yeah.
It's my privilege to introduce today's speaker, Dr. Yves Joanette. Dr. Yves Joanette is Professor of Cognitive Neurosciences and Aging at the Faculty of Medicine of Université de Montréal. He is currently the Scientific Director of the Institute of Aging of Canadian Institutes of Health Research. He is the Scientific Lead of CIHR Dementia Research Strategy and act as co-lead of other initiatives on e-health and on healthy and productive work. Yves Joanette is also overseeing the Cognitive Neurosciences and Aging Research, Healthy and Productive Work. He's also the overseer for the Canadian Longitudinal Study on Aging. He sits on many international advisory and management boards, including European initiatives in which Canada participates. Whereas Joanette is member of steering committee of the Joint Programming Initiative, More Better Lives, member of Center for the Future of Aging of the Milind Institute, and was recently elected chair of the World Dementia Council. Whereas Joanette has been scholar and scientist of the Canadian Medical Research Council and has received many distinctions, including the André Dupont Award and the Yves Award for Exceptional Professional Accomplishment. Whereas Joanette is a fellow of Canadian Academy of Health Science, the University Lumiere de Lorraine presented him with an honorary doctorate. Thank you, sir, for giving. Thank you, sir, for.
Yeah. Thank you, Dr. Rosie, for the introduction of Dr. Wes.
Okay.
I think Dr. Parle has joined back. We can continue his talk, and then we can request Dr. Wes to deliver his talk.
Yes, can you hear me?
Parle, sir, please.
Fine.
Yeah, we can hear you, sir, please.
It looks there was some problem in the connectivity.
Yes, sir, it happens. You are in the second slide.
So
Please continue.
We are in this slide, and now see, when we are with a patient suffering from.
Sir, please switch on your video so that you are visible.
Okay, is it okay now?
Yes, sir.
Right.
Fine, sir.
So we have to, with the patient, you need not use words. You have to listen with your ears, and not only ears, but with eyes and your heart. You have to reach the patient. You may clap, you may hug the patient. You have to show your expression of affection. Yes, next slide, please. Now I'll tell you different types of dementia. This is very important, First, I'll discuss those which are uncommon dementia types. We have, say, Parkinson's dementia. Here, substantia nigra, which is very rich in dopamine, their degeneration takes place, and one loses control over his motor activities, and at advanced stage of Parkinson's disease, one experiences total memory loss, and there is confusion also. There is another dementia which is Huntington type of dementia. This is very rare. It has same name as Huntington's disease or Huntington's chorea, or even dancing disease. This is also known as dancing disease because patient makes involuntary movements of his limbs as if he is dancing, and there is a three-way loss of dysfunction. Your cognitive functions are lost, your emotional psychiatric disorders are there, and your physical activity also is impaired. There may be ataxia. So this is a very serious disorder. It is genetic, and this starts at an early age. So those who have crossed 30 years of age, you are not suffering from this, and it has a family history, very strong family history. The next one is Creutzfeldt-Jakob dementia. Here, misfolded prion proteins, they occupy the brain cells, and they impair and produce anxiety, depression, total memory loss, confusion, impaired judgment. Then we have Wernicke-Korsakoff. These are actually two disorders, Wernicke's encephalopathy and Korsakoff psychosis. I'm talking of different types of dementia. We are all aware of Alzheimer's type of dementia. In addition to Alzheimer's dementia, there are several dementias. So Wernicke dementia, here the cause is chronic alcoholism. And when you have taken alcohol for a long period, it can get converted into Korsakoff dementia or Korsakoff psychosis. Here, in order to cover memory loss, patient starts making stories. Based on his experiences, he'll make such stories that they may appear real. They may appear real. Yes, there is a loss of control over bowel movements, bladder. It's a pitiable condition. Then mixed dementia. We also have mixed dementia. Mixed dementia is one where you have multiple disorders. Say you have alcoholism along with Parkinson's disease. Then you see mixed dementia when several disorders are together. So when we are with such a patient, let me tell you, for alcohol, it is an amnesia. For Alzheimer's, your retrograde memories are not lost. Your old memories are not lost. You may forget what happened 30 minutes before. You may forget. You'll not remember whether you had a cup of tea or coffee, or whether you had morning breakfast or not. But you will remember everything that happened 30 years ago. Your old memories are intact. So here we see a small child showing to his grandmother an old photograph album, and there the lady gets absorbed and is able to recollect all old days, her school days, her executive office days, marriage days. She is able to recollect everything, and this is one way we can take care of the elderly patients. Now coming to common types of dementia. Alzheimer's dementia, yes, this is the major type of dementia. Dementia is a hallmark of Alzheimer's disease. Almost 60 to 80% of the patients suffer from Alzheimer's disease and they show dementia. Other dementias are very, very rare. In Alzheimer's, we have aphasia, where there is loss of expression, loss of language, one fumbles for words. Apraxia, loss of motor abilities are there. Then we have agnosia, we are unable to identify the objects. There is loss of judgment. So these are all different types of dementia which we see in a patient suffering from Alzheimer's disease. Alzheimer's disease is more common beyond 65 years of age. See, in 2000, India had a very small population, around 10 million patients were there. In 2020, we have around 36 million patients suffering from Alzheimer's disease. So you can imagine over the years, lifespan has increased and the number of patients also of Alzheimer's disease have increased. Next common dementia, around 10% of the dementia patients suffer from vascular dementia. In vascular dementia, what happens is there is reduced blood flow to your brain. And when there is reduced blood flow, reduced glucose supply to brain, naturally there is a memory loss. So this is the first brain dysfunction which takes place. This also happens in stroke. Then alcoholic dementia, I will not call it dementia because it is, if you are taking alcohol for the first time, if you are not a chronic alcoholic, it's only amnesia. I'll tell you the difference between amnesia and dementia. Dementia, there is an organic disorder. We have loss of neurons, loss of cholinergic neurons, loss of neurotransmitters, loss of brain cells due to degeneration. In amnesia, there is no loss. It is reversible. It is totally curable. So as soon as the effect of alcohol is over, the person is normal. So he has normal memory. Then next type of dementia, which is only in 5% of dementia patients, is frontotemporal dementia. When your frontal and temporal lobe of brain is affected, there is frontotemporal dementia. Here also you lose your language, you are unable to take a decision, you are unable to judge, judgment lacking is there. And the next type of dementia is Lewy body dementia. So Lewy body dementia, here there is deposition of Lewy bodies in the brain which interferes with transmission of neurotransmission, transmission of signals. So I just revise common types of dementia. We have Lewy body dementia, Even Lewy bodies get deposited in the brain. We have frontotemporal dementia, where you have frontal and temporal brain cells which are degenerated. We have alcoholic dementia, which is reversible. Vascular dementia, you can remember, blood vessels get narrowed and there is reduced blood flow. This happens in hypotensive patients. Patients who have, say, very low blood pressure or very high blood pressure, there is vasoconstriction. There again, there will be reduced blood flow to the brain, and Alzheimer's dementia. Now, such patients, the patients who are suffering from dementia, who are elderly, have a feeling that they are not wanted. They have become worthless. They have lost their all skills. They do not remember anything. They have no earning value at home, and therefore they feel disappointed and dejected. So you show your care, show your love. You tell them, you identify them with their name, tell your relation to them, and then you can develop a bond. A bond can be developed between the caregiver and the patient. Then the patient becomes more cooperative. Then yes, in order to cure the patients with dementia, as we do exercise for our body, there is a necessity to do some kind of exercise for your brain. You need to stimulate neurogenesis. You need to activate your brain cells. If not, you can at least delay, you can arrest the process of neurodegeneration. So chess is one method by which your brain is activated. Solving Sudoku, puzzles, riddles, this also helps. Then yes, dementia patients, they like to laugh. They enjoy a sense of humor. So laughter is the best medicine. You visit a patient who is suffering from dementia and you tell him a joke and you laugh. When you laugh, your diaphragm muscles are relaxed. The toxins from the body, from the caregiver as well as the patient, are removed from your body and you become little active. Life becomes worth living. So maintain your sense of humor. I am giving you all, these are the tips for caregivers. Our theme of today's talk is difficulties we face in dealing with the patient suffering from dementia. The theme is difficulties caregivers face in dealing with the patients suffering from dementia. See, at an old age, you cannot expect an elderly person to change. It's not possible. Whatever behavior an elderly person has, if he is feeling dejected, if he is feeling depressed, he is depressed. You cannot change him. And his behavior is triggered. I have seen an old person, he will remove all the clothes from his cupboard or from his bag, he will remove all the pants, shirts, tie, everything. There is some trigger in his body. Either he wants to be busy organizing these clothes or he wants to attract attention of the members at home. So don't scold at such a person. Never scold at such persons. Never shout at these persons. See, they'll be hurt. Already they have become very sensitive. Be soft. Be cool. They will not change the behavior. We can change the behavior. We have to change our behavior. And then you will find that they become cooperative. Yes, physical activity we have to encourage. Walking is the best physical activity at all ages, particularly at elderly age. If there is a campus around, if there is a small park around, or some corridor, some place around your house, you hold the hand of the elderly patient and take a walk. You will also have an exercise and the patient also will have an exercise. Exercise, I need not repeat as a pharmacologist, you require exercise for better absorption of the food you have taken, better digestion, better absorption, better excretion, better circulation of your blood, better heart function, better kidney function, better brain function. All these activities are possible at all ages, even younger students who are here. Sometimes I find, in COVID era, they're all indoors, and in places like Delhi, Bombay, there are no parks or open spaces, and there is no way they can go to a gym, and they are locked inside, and either their health have a lot of problems, there is no workout, or they put on weight, or some kind of diarrhea or different gastric upsets, mental upsets, psychiatric problems start up. So we have to encourage physical activity at all ages, particularly when the patient is old. Yes, dehydration. As you grow old, you don't like taking fluids, or you may have hesitation. So maintain hydration. Take adequate fluids. Have fruit juice, tea, coffee, or just lemon sherbet or glass of water. But keep taking fluid. So caregiver, if sometimes it happens that patient gets upset, so you just change the topic and say, let's have some snacks, let's have some fluid, and you can give fluid. That will also maintain hydration. Here we see a patient who is not going to listen to the caregiver. He is angry with himself. Now, in such a situation, you have to be soft. You have to be patient. You have to win the heart of the person. You have to take such steps, by which either make him recall old memories, or you can say sorry if something has gone wrong. Don't raise your voice. Patient is upset. You don't get upset. See, there are chances. It's very difficult to take care of such patients. One gets frustrated. The caregiver himself, there is a risk, may undergo depression. The caregiver may have a feeling that his entire life is being wasted after taking care of such a patient. We also have, there are two kinds of caregivers. We have family persons, relatives taking care. We also have paid caregivers. We can hire nurses, we can hire attendants, and there are professionals available, and there are elderly homes, and those can be hired who are trained, who have been given training how to take care of elderly persons, and we can avail their services as well. Yes, you have to be creative. Don't be under the impression that what worked yesterday will also work today, or the idea which you made the patient cooperative yesterday will also work today, or what works today will work tomorrow. No, we have to be creative. Here I see the elderly patient playing over some blocks and trying to make a house. So tomorrow you can bring a Meccano, you can bring a different game, and you can give a small task saying that after we complete this, let's have a cup of coffee. You can keep some incentive, and this way the patient will become cooperative, patient will not reject his medicines, and you develop a bond, an unknown bond, even with the outsider, even with the foreigner is developed. And if the person is your loved one, there is no pleasure like that. Thank you, and thank you so much for patiently listening. Thank you, one and all.
Thank you, sir. Thank you for your valuable insights on what are the challenges and difficulties faced by a dementia patient, and how a caregiver can overcome, or how a caregiver can help them to overcome these challenges and difficulties for a dementia patient. Thank you so much, sir. Now I request today's speaker, Dr. Joanette, to deliver the talk.
Hello, everyone. I regret I'm not able to be physically with you in Maizuru, but it is a pleasure to be there virtually. At least this is the way it can be done this year. We are very, of course, we think about all of our friends in India, and our colleagues, and all of you and your family because we know how the situation is really difficult for you, as it is for many other people on the planet. It was, and it's still difficult here in Canada and Quebec. We had a number of fatalities in the long-term care centers in particular, and Quebec has been one of the places where this disease has been the most devastating in terms of number of people deceased because of the fact that unfortunately for some reasons it entered some long-term care facilities and so was the source of a lot of damage and lives taken. But I'm really happy to be with all of you, and thanks to technology, I'll be able to share some of what we're working on and some of the ideas. And one thing I would like to share with you today is all about the brain aging and about communication in normal aging and also in dementia and cognitive disorders. So I'm going to share with you these slides during the next approximately 25-30 minutes. And you'll be able to see me here in the little corner. Here I am. And so let's...
Hello, everyone. I regret Guru, but it is at least, this is the way.
Hello, everyone. Is really difficult for you, as it is for many other people on the planet. It was, and it's still difficult here in Canada and Quebec. We had a number of fatalities, aging, and about communication in normal aging and also in dementia and cognitive disorders. So I'm going to share with you these slides during the next approximately 25-30 minutes. And you'll be able to see me here in the little corner. Here I am. And so let's talk a little bit about communication abilities and how communication abilities is the meeting point of cognition across life and life events such as the one we're all living currently. Communication is there as we're born. I mean, the first thing that we do as babies is not necessarily to give a course or walk. We communicate without language, but we communicate with our facial expression and so on. And this communication follows us and is really important all around and throughout infancy. And we see here how kids are communicating between themselves, and at a certain point in life, communication becomes even more emotionally loaded. And we all, many of us lived through this to this period. And then throughout lifespan,
dear delegates, he's finding some small technical issue. He will be joining very soon, in 2 minutes. Hello? Can you hear me?
Yes, sir.
Yeah. He'll be joining us
Hello,
very soon.
everyone.
Yeah.
I regret I'm not able to be physically with you in Mysuru, but it is a pleasure to be there virtually. At least this
hello,
is
everyone.
the way it can be done this year. We are very, of course, we
about communication.
think about
in
all of our friends
in dementia,
in India,
and
and our
cognitive
colleagues,
disorders. So
all of you
I'm
family,
going to share
because
with
we
you
know
these slides during the next
the
approximately
situation
25
is
30
really
minutes. And
difficult
you'll be
for
able to see me here.
you as it is
Here in the
for
little corner. Here I am.
many other people on the planet. It was
And
still
so
difficult
let's talk a little bit about communication
here in
abilities and how communication
Canada.
abilities is the meeting point
Quebec.
of cognition
We
across
have
life in life.
A number of fatalities in the long-term care centers in particular. Quebec has been one of the places where this disease has been the most devastating in terms of number of
Events such as the one we're all
people
living currently.
deceased because
Communication is there as we're born.
of the fact
I mean,
that
the first thing
unfortunately,
that we do
for
as
some
babies is
reasons,
not necessarily to
it entered some
give a course
long
or walk.
care
We
facilities,
communicate without
and
language,
so
but
was
we communicate with our facial expression
source of
and so
a
on.
lot
And this communication
of
follows us and is really important
damage
all around and throughout
lives
infancy. And we see here how
taken.
kids are
But
communicating
I'm
between
really
themselves,
happy
and at a certain point in life,
to
communication
be
becomes
with all
even
of you,
more emotionally
and
loaded,
thanks to
and we
technology,
all,
I'm
many of us lived through this to this period, and then throughout
be able to
life's
share
span,
some
communication is very important
of
in terms of intergeneration, and so communication is everywhere in our life, everywhere. And I know that in India, you love communicating and talking. So and you do it in a very direct and in a very
we are working on
nice manner. I have
and
marvelous
some of the
communication
ideas.
events in India with colleagues, but
Yes,
also
and
with
one thing
taxi drivers and people in at markets and so on. So it's really something that you know what I'm talking about. And you know that at least in our countries here in Canada and Europe, communication is very important when you get older, because if you can walk a little bit less and if you can enjoy a little bit less other aspects of life, communication is. Hello, everyone. With cognitive disorders with dementia who are suddenly seeing in long-term care facilities or in their family, their caregivers with masks.
Oh yeah, I'm doing that. There is some problem going on with this. It's fast. I've connected another one now. I think this will be quicker.
Hello, everyone. I regret I'm not able to be physically with you in Maizuru, but it is a pleasure to be. Important. And we had to evolve recently to communicate without being able to see part of the face is not something usual. And in fact, it has interfered with communication. And think of all those people with cognitive disorders, with dementia, who are suddenly seeing in long-term care facilities or in their family, their caregivers with masks, with where do these masks come from? And so it increases the confusion, it increases, and also it decreases the facial expression and emotional component of communication that can be conveyed. And as we are doing now, we also learned, a lot of us, to communicate through those software that allow us to meet a lot of people, but not in the same place, which is unfortunate, because it's important to be able to be in the same room, not only to communicate content, but also to live together a moment. But those software are certainly not really interesting, but they are important to palliate for the absence of physical presence that we have to respect. So communication, in fact, for me, and here's a World Health Organization document or graphic showing the determinants of active aging. Well, communication is in fact central. Communication is central because it's the glue that between people that allows for social connectedness and also the expression of health needs and social needs and personal opinions and moods and to together influence the environment and so on and so on. So for me and for many of us, communication is central to a healthy life trajectory. It's just as if we as humans, as persons, would be like the most sophisticated cell that we have in our body. And you know that the most sophisticated cell that we have in our body is our neurons, and neurons are characterized by the fact that they have an axon, kind of a cable that connects to another neuron. Well, it connects because it communicates. And this sophisticated cell, which makes the brain is made of neurons, other cells supporting the neurons, but essentially the neurons are the ones connecting themselves and allowing you to think, see, hear, speak, feel, smell. And these neurons, when you cut, when we communicate with other people, we're kind of just like neurons communicating with other neurons, so to say. And what happens when when you cut the axon, this cable here between the cell and the next cell, just as if you stop communication, what's happening? Well, the neuron dies. And if you think about it, if you isolate someone and if that person does not have the ability to communicate with others, he or she will mentally, so to say, nearly die, just because it's so basic for us to be able to communicate. And communication here is not only verbal, it's not only the language is also the signs, the emotion, and so on. And that's why for us and for me and my group, communication is really important. So what's communication? So you have here a layer of communication which goes from, let's say, I have the intention to say to you something, like what I'm explaining to you now. It has to go through a series of adjustments or levels of preparation of the message, of the articulation, because here below here you have the sounds, but between the intention and the sound, you have to first use the pragmatic layer. In other words, I'm going to adapt my language to what I think you can understand of what I'm saying. So this adaptation to the environment, you don't speak the same way to your children than you speak to your boss, so to say. And then you have to organize your discourse. Is it a narration, different types of discourse, or if it's a conversation, to respect the rules of turn taking, and then you have to transform it into sentences, and then choose the words, and then choose the sounds, and then articulate the sounds. So this is more or less the mechanics and the concept of articulation. And the intention might be very logical, deductive, encyclopedic, so to say, just like I'm telling you, what are the steps to use a certain machine, or how to change a tire if you have a flat tire in the car. But it can be used to convey emotions. And so communication is certainly not always simply logical, deductive information, but it's a lot about emotions. And in fact, I don't think that you can think of any communication event that has no emotion. And I know in India, like in many other cultures, emotions are very important when you communicate. And you, some years ago, the first times I was in India, you even have some movements of the head that are conveying aspects of emotion as you communicate, even though not everyone is aware of those movements of the head. Anyways, if we go back to communication, so where is communication in the brain? Is there a place there? Well, some old understanding of how the brain works, phrenology in the late 19th century, thought that every aspect of human behavior was somewhat positioned somewhere in the brain, which is, of course, we know is wrong. So there's no center of communication or language which would be independent from, and in fact, in this particular model, language was more or less here in the orbital portion of the brain. But you also have here literary sentiments, but also mathematics, music, and so on. And the brain is not organized like this. In fact, as I frequently tell to my students, the brain is not organized like the departments of the University of Delhi, for instance. You don't have a faculty of education or a center for education in the brain, and a center for music in the brain, and center for science or for arts. It doesn't work like this. It works for universities. It doesn't work for the brain. The brain is not organized that way. And how is communication organized? And that's important because you'll see it's very central to cognition. The brain, well, we know, or we identify different behaviors or domains of cognition by clusters, right? We say, here's something that's called language, and here's something that's called memory. Well, we know first that, of course, this is useful for us. Doesn't mean the brain knows where memory is or where the language is. And not only that, but we also know that there are subcomponents. For instance, memory. There is the working memory, in other words, the memory you're now using to put in your mind the beginning of my sentence in order to try to connect and understand the whole sentence when it will be finished now. So that was working memory. It's also the memory used when you go from the phone book to the telephone in the other room in your house. You have to keep in your mind, the number, and that you repeat yourself, but of course you'll forget about it. And then there's episodic memory. So those moments in your life, first time you did some bicycle alone, first time you cooked an egg, I don't know. And then there's semantic memory, which is the memory about the world. We know that you know certainly what an elephant is, but you know also what a seal is and what a moose is, even though you probably never crossed one in the streets of Mysuru. At the same time, other aspects of cognition, like language, has those things I told you earlier about the layers and the components of language, like discourse, pragmatics, phonology, syntax. But there are also components of language which are shared with memory. So semantic memory is where also the concepts are. And one way of expressing a concept is either a typical picture or a word. So the words are part of semantic memory. And words are not stocked isolatedly. They're attached to concepts which have other aspects or routes to access those concepts, such as you can, if I say the word rose, well, you can understand the word rose. You can say, you know that it spells R-O-S-E, but you also smell the rose. You can also feel the rose if you ever try to pick the rose by the stem, and so on and so on. But is it the way, because these are like faculties, these are like departments, like the University of Delhi, is it the way the brain is organized? Not at all. The brain, in fact, is organized in such a way that there are cognitive processes. So this is the brain level here. This is what we think or we see at the surface. And in the brain, there are neural circuits, there are networks that will do, let's say, long-term maintenance. So they will be useful for a number of those things here. Other will help with planification, with inhibition. If you speak many languages, for instance, and I know this is the case for many of you listening because you speak lots of languages typically in India, when you you switch from one language to another, you have to inhibit the others not to come. And so inhibition here is something important, but it's also useful in other aspects of life, not only for bilingualism. Syntactic rules, planification. So this is where the brain is. And what I just want to bring your attention to is that language and communication abilities, because of the complexity of the behavior language, because of what it requires, it probably involves a lot of those basic cognitive processes, probably more than any other aspect of cognition. That's why I think language is central to cognition. So how does language and the brain evolve, and how does the brain and language evolve, like, let's say, during life, from left to right here, or throughout a life event, such as the one we're living currently? So first of all, let's see in life trajectory, in aging and in dementia. We know that as we get older, we kind of lose some neurons and we lose some white matter in the brain. And this is normal. It's not normal when you lose too much, then it's because of a disease. but it's normal to lose. And here's a disease picture. You see here some infratemporal atrophy in a older person with Alzheimer's disease, but the same area in a 75-year-old normal person will not be atrophied. So it's normal to lose some portions of your brain when you get older, but it's not normal to lose too much, and that's when you have disease. Now, is it you know, why are we losing neurons? In fact, you have to know that the period in life where you lose the most neurons are probably the first 2 years of life, even the first year. Because when we're born, it's like if we have all the potential, the pluripotential of the brain, we have all the neurons, and it's kind of it's like if all the neurons would be connected with all the other neurons. And as we learn the language in which we are born, as we start walking and start behaving and start being a human person, in the social sense of the word, we don't make connections. We simply delete the connections we don't need. So it's like when you do, let's say, a sculpture, you start with a piece of wood or a piece of marble, and you move out some material if you want to do something. You don't glue some material to a small beginning part of the wood or of the marble to create a sculpture. You remove. So it's like so it's normal. And the more you remove, the best you know, the more the sculpture is refined. So you can say that removing excessive connections and neurons in the brain is in fact an evolution. So it's not, don't take it as negative, it's in fact positive. And what would not be positive would be to keep everything in place, because then you would have a block of marble or a block of or a piece of wood without any carving, without any sculpture. And in fact, this loss of neuron, which again is not necessarily negative, does not occur in the same way in all the parts of the brain. And one part that loses more than others is the hippocampus, which we know is important in order to contribute to bringing new memories in. But maybe we were made in such a way that's at the end at a certain point in life, in the trajectory of life, we don't need to bring more too much, because we know a lot. We have wisdom and we have knowledge. So maybe it's simply a good thing not to have too much new stuff being put in the brain each time. And different parts of the brain age differently. Here you see, just look at the different colors. Don't look too specifically, but you see that in terms of the gray matter, which are neurons, or the white matter, which are the fibers between the neurons, it's not the way the brain evolves with age normally is not equal. And this is we don't know exactly why, but I can't refrain not to mention a study that just was finished in my lab with Hania Mohammadi and Frédéric Lesage, where in fact it was studied through functional imaging, MRI, and also near-infrared spectroscopy and behavioral aspect. We looked at something which is very simple, because we're wondering why is it so that the different parts of the brain do not age the same or do not lose gray matter in an equal manner? Is it predetermined, or is it in reaction to something? Well, I was telling you about this the recent study where we looked at what's called brain pulsatility. Pulsatility, as you see here, is each time your heart pumps blood into the arteries and in the brain, it creates a pulse, right? It creates a big amount of blood, which comes. And this amount of blood will be absorbed by the elasticity of the arteries. So the arteries will react to the blood and then make the flow of the blood smooth. However, with aging, you have indeed stiffer arteries, and because the arteries become a little bit stiffer, there's more variation in the blood flow, and pulsatility will increase. Pulsatility is the ability you have to feel this this change of pressure. And of course, this is even worse if you have cardiovascular risk factors, and this is can be the case in many people in the population. So it's possible to measure this pulsatility and this pressure and so on with, among other things, with near-infrared spectroscopy using light and so on. And here we see Hanye, my PhD student, who now finished, terminated her PhD, installing. These are not going in the head here. It's simply on the surface. They're simply lights, and lights capture and lights put in the brain, and then also put in the magnetic resonance imaging. And what we see here is that, and that we were not expecting. You see little shades of color here in younger and older adults. And in older adults, what you see is that changes in pulsatility is not distributed equally in the brain. And the map of this distribution is very similar to the one I told you, or I showed you earlier, about the areas of the brain which are more affected in aging. So in other words, the fact that different areas of the brains are affected differently in aging is probably due to a hemodynamic reason, where because we age and because the arteries become stiffer, and it's even worse when you have cardiovascular diseases, which we know are frequently associated with mixed forms of dementia and even Alzheimer's dementia, then all this is probably linked, and makes it an interesting explanation, or at least a co-occurrence of events, which now we better understand. The result is this graph, which is a very classic graph by Shea, where different areas of cognition have been looked at in people of different age. And what you see here is that some areas like numeric abilities or even perceptual speed, they tend to go less performant as you age, but that the area of cognition, the aspect of cognition that is most maintained, is around verbal ability and verbal memory. And so this is interesting, because it's as if language and language abilities, and this is only one glimpse on this phenomenon. Language abilities is one of the abilities that is most maintained with aging, as if it was predicted or known that to communicate is important to have a good, a healthy life trajectory. And so some people have looked at this difference between some aspects of cognition which are better maintained than others. And there is a paradox, because I told you there's losses in neurons and white matter, but some cognitive abilities are maintained. So why is it so? And the notion of cognitive reserve was introduced many years ago by Jakob Stern, a colleague from New York. And this is the cognitive reserve is not something that is in the brain. It's simply a concept that allows us to say that we probably have some ability to maintain some reserve in some cognitive abilities in such a way that even if the brain is affected by either aging or even diseases, we maintain that ability. And again, language is probably one of those abilities that is most maintained. And another colleague from Duke University, Roberto Besa, has described some phenomenon in the brain that seems to be associated with this cognitive reserve. And in general, you could say that here are three brains, one young person, two older person. You see them from the front here. So these are the frontal lobes. It's like if they were looking at you. And here you see don't mind the exact experiment here, but here's an experiment where we see activations that characterize this particular response asked to the participant in a young participant, which is on one side of the brain. And if you look at older people, if they have like a little bit more, but essentially if they're using the same way of doing things in their brain in terms of networks, these are the older individuals where the performance are lowered. And in fact, those older person who are like nearly comparable to the younger ones, they are frequently, if not always, characterized by the fact that they're doing the same thing, but bringing together not only what was going on in the hemisphere, but also the other side of the brain. So there's an adaptation, there's an evolution in order to maintain the ability. So that's very important. What I'm saying here is I told you, with aging, you can maintain in some areas, and particularly communication,
where
those
the performance are lowered.
The fact that the brain
And
loses some
in
neurons,
fact, those
but the brain
older person who are like
does not realize
nearly
or does not support this ability the same way. It adapts, it evolves. And so every day we wake up, even though we do the same thing every day, as we advance in the trajectory of life, the brain adapts and do it a little bit differently in order to maintain it and maintain the ability for it to be happening. I will not show you this because I'm just looking at my watch here, and the organizers will not like me if I go too much, in fact, in the time here. Just want to say to you that we have seen this over and over again. This is from my lab. This is a very simple experiment. Younger and older patients are performing similarly in word fluency tests. And despite that, here's the network in younger participants. See, look at all the connections needed. This is the same network, or the network for older participants for the same performance. And you see that the older patients or participants need less brain to do the same thing, which is quite interesting, eh? And we did the same here, looking in particular on how the distribution, and we see that younger we're using more the frontal part, and older the back part of the brain, the temporal part, where semantic memory is, where the knowledge of the world is. And it's normal, because as we grow older, the knowledge of the world compensates if we're not able to induce or use some executive function, which are mostly supported by frontal areas. With Ikram Metkal, another student of mine, we did a study. I'll go very quickly, but essentially the same. What characterized the older was activation in the posterior part of the brain, whereas what characterizes the younger was in the frontal part of the brain, anterior part of the brain, for the same task and for the same performance. So even though we maintain performance, the brain changes with age. So what's happening with in some life events like what we're living together, where currently where we have to wear masks, which interferes with the expression of emotions, lower sound volume, absence of lip reading. And it's a bizarre situation for those with dementia, as I was mentioning. The software, which, teleconferencing, it's not natural, but at least it allows reaching out to older individuals in isolation for sanitary condition, because older people, they love tablets, they love iPads when they have access to it, if possible. So one thing that just want to mention is exactly the use of emotional communication through my colleague Ana Inés Ansaldo. We frequently or always travel together to India, so I just wanted to mention some of the work she's doing. And in this work called the Compass, there is a software, in fact, sorry, an application on iPads,
Thank you so much, Dr. Yves, for the excellent talk. He's again facing some internet issues. Yeah. Are there any questions which can be taken, Rosa?
Yes, sir, we have one question. With what approaches we can attain medication adherence to prevent mortality and morbidity in elderly and dementia patients?
Can you come again? Can you read the question again?
With what approaches we can attain medication adherence to prevent mortality and morbidity in elderly and dementia patients?
Can you answer that question, Parle sir?
Right. I think the question is that, can you hear me?
Yes, sir.
That how can the morbidity and mortality can be reduced, isn't it?
Yes, sir. By attaining medication adherence.
By medication.
So with what approaches we can attain medication adherence to prevent mortality and morbidity in elderly and dementia patients?
Yeah, right. See, we have medications, and normally the disease of Alzheimer's disease appears in elderly patients. So in addition to Alzheimer's, it is likely that the patient has some other chronic diseases. He can have blood pressure, he can have diabetes, he can have hypercholesterolemia. Now, to address these points, the approach should be first take medications for reducing the blood pressure, then take medications for reducing your hyperglycemia, glucose levels, then cholesterol levels. That way you can reduce the mortality. And for memory enhancing also, we have some memory enhancers available in the market. Cholinesterase inhibitors, we have rivastigmine, we have galantamine, we have donepezil, and we also have some nootropic agents like piracetam, femiracetam, pramiracetam. These can be taken. This will reduce the morbidity and mortality.
Thank you, sir. That was very good information for the particular question, sir. And I thank Dr. Yves Joanette for giving valuable insights on cognition and cognitive difficulties in dementia patients. So now I call upon Mr. Vinay Kola to propose the vote of thanks.
Good afternoon, all. Thank you, RC Mysuru, for providing me this opportunity to propose a vote of thanks for today's session. Firstly, I would like to thank our chief guest, Dr. Milind Parle, for your presence and blessings for today's session, sir. Thank you, sir, for explaining different types of diseases related to dementia and cognitive difficulties being faced by dementia community. Thank you, sir, for your inputs. Secondly, I would like to thank Dr. Joanette for your valuable inputs on cognition and communication difficulties in dementia in detail, which has enlightened the awareness on various challenges being faced by dementia people and how to overcome the same. I would like to thank Dr. Hanumanthachar Joshi, Principal, Sharda Vilas College of Pharmacy, President, APSE Mysuru Chapter, and President, H. Mysuru Chapter, for your all-round immense support to make this program a success. I thank all my colleagues of Sharda Vilas College of Pharmacy for your continuous support. Last but not the least, I thank each and every delegate who ever participated by sparing your valuable time today. Thank you very much. Thank you.
Thanks to you. Thank you.